Hey friends, welcome back to Med School Moose. In this video, we are going to be breaking down the chief complaint of lower abdominal pain and everything that you need to know to be successful on your emergency medicine sub-I rotation or your away rotation. In the last video, we talked about upper abdominal pain. If you haven't checked that out yet, I will link it right here. As always, this information is relevant for fourth-year medical students that are in an emergency medicine away rotation, first-year EM residents, third-year medical students going into an EM rotation, or anyone that's just interested in emergency medicine like I am. Of course, this is just educational only. This is not professional medical advice, so let's jump into it. Same outline as always. We are going to start at the top with the highest yield, the differential diagnosis, starting there with the can't miss diagnoses, some of the lower acuity things, and the zebras that we need to be on the lookout for, some critical questions we need to be asking when we're interviewing these patients, some of the important things that we need to do when it comes to the physical exam, how we're going to work these patients up, and then some miscellaneous pearls at the end. So starting with that differential diagnosis and starting with the can't miss diagnoses. Right at the top, we're going to start with acute mesenteric ischemia. Of course, I mentioned this when we were talking about upper abdominal pain. This is still relevant when it comes to lower abdominal pain. Some similar things that we're going to be seeing here on this can't miss differential. Bowel perforation, of course, is still there. Ectopic pregnancy is one that we absolutely can't miss. Remember, when it comes to medicine, all women of reproductive age are pregnant until proven otherwise, and all pregnancies are ectopic until proven otherwise. So you definitely need to make sure that you're not missing that. Of course, when it comes to lower abdominal pain, we want to consider GU complaints, so things like testicular torsion, ovarian torsion, which are emergencies that you cannot miss. Acute appendicitis, especially in patients presenting with that classic right lower quadrant abdominal pain. A lower GI bleed, especially in our elderly patients if they're presenting with melena or hematochezia. Pyelonephritis is another can't miss diagnosis because this is an ascending infection that's kind of affecting the kidney now. And another one that I want you to keep on the differential as a can't miss is urinary retention. This is something that you'll catch, especially in your elderly patients. The reason that I'm putting this as a can't miss diagnosis is because urinary retention can cause a lot of problems, abdominal pain, renal failure, things like that. I recently had an elderly patient that came into the hospital for weakness, not even abdominal pain, just weakness, and he had a mildly distended abdomen. He wasn't even very tender when I touched him. Lo and behold, he had about 2.8 liters of urine in his bladder, which was absolutely ridiculous. Urinary retention can be a very serious problem. Fortunately for that patient, it wasn't, but it can cause a host of serious problems. Of course, this list of can't miss diagnoses is a little bit longer than some of the other ones. Abdominal pain is the most common complaint when it comes to patients in the emergency department, and this is not all inclusive, but these are some of the important ones that I think you need to know. Moving on to some of the lower acuity stuff, right at the top is going to be diverticulitis. Now, again, this is something that can certainly be more severe if patients have signs of perforation or if they have an abscess, but tends to be a little bit lower acuity. Same thing with bowel obstruction. Most of these cases are mild and can be treated with bowel rest. Of course, sometimes they are more serious, they are more severe, and will require intervention, but we're going to keep it on lower acuity right now. Constipation stays on lower acuity when it comes to lower abdominal pain. Of course, other things like urinary tract infection or pyelonephritis can sometimes cause lower abdominal pain, suprapubic pain, flank pain. Typically, these patients have more urinary symptoms associated with it, but certainly something that we want to keep on the differential when it comes to lower abdominal pain, as well as nephrolithiasis. And then in addition to that, hernias, as well as an abdominal muscle strain, just like we talked about in the upper abdominal pain video, especially in these patients with a history of heavy lifting or straining or something like that. And then some of the zebras when it comes to lower abdominal pain, not as common, but can absolutely be very serious, starting with a ruptured AAA, a ruptured abdominal aortic aneurysm. I recently had a patient that came into the hospital with a known history of a AAA. He came in with acute onset left lower quadrant abdominal pain. He was hypertensive, he was uncomfortable, he was vomiting, and he had a ruptured AAA. So it's not common, but it is something that you will see in the emergency department, so you do need to keep it on your differential. Volvulus, not very common either, but it can be seen in our younger patients, our older patients, and this can sometimes be a surgical emergency. Ruptured hemorrhagic cyst, not very common, but a lot of female patients that come in with like lower abdominal or pelvic pain, if you do an ultrasound, you might see signs of a ruptured hemorrhagic cyst. So certainly something to keep on the differential that can cause a lot of pain. Fournier's gangrene, can't miss this one. It's a zebra. It's not very common, but you can't miss it. You need to be examining the groin, which we'll talk about a little bit later. And then pelvic inflammatory disease, especially in our female patients, we want to be asking about some other GU symptoms that they may be having as well. And going into that, some of the critical questions that we need to be asking, in addition to our typical old carts, we want to be asking if our patients had a change in bowel movements. And this can be a lot of different things, right? It could be constipation, diarrhea, melena, hematochezia. Are they passing gas? If they're not, maybe we're concerned about a bowel obstruction. medicine. These are important things that we need to be asking. We want to be asking if they have a history of GU pain. That might lead us more down the path of evaluating for ovarian torsion or testicular torsion or something like pelvic inflammatory disease or ectopic pregnancy. And of course, asking if they have a history of abdominal surgeries. Remember, a history of prior abdominal surgeries increases the risk of formation of adhesions, which increases the risk of bowel obstruction. So knowing those kinds of things are helpful in determining the patient's risk for some of these diagnoses. Of course, there are some other questions that we want to be asking. We want to ask our female patients if there's any chance they could be pregnant. Even if they say no, we're still going to get that pregnancy test because all women of reproductive age are pregnant until proven otherwise. So now let's move on to the physical exam. And a lot of this is going to be similar to when we're evaluating upper abdominal pain. We still want to make sure that we're getting a good exam, relaxing that abdominal wall musculature, making sure that if the patient's lying down, we get their knees up so the abdominal wall is relaxed. Make sure if the patient's in a hallway bed or a chair that we're leaning them back as best as we can to get a reliable exam. Don't be afraid to do deep palpation to really localize where that pain is, to see if there's any signs of organomegaly, that kind of thing. Assessing for peritonitis, if the patient's abdomen is tender with even light palpation, if it's rigid, if it's rock hard, those are concerning things that we definitely want to know because there could be a surgical emergency when it comes to the abdomen. And like I just said, you absolutely have to do a GU exam. You have to look in the groin, especially if the patient is having GU complaints. One other important thing that I want to mention here, some of the physical exam maneuvers or exam findings that we might see, like McBurney's point or Roving sign when it comes to acute appendicitis, those are great to do, and they might be specific. You know, if they're positive, they increase your suspicion for something like acute appendicitis, but they are by no means sensitive. If it's negative, that does not mean that you have ruled out acute appendicitis. So while they are helpful, they are not very reliable, especially when they're negative. They have low sensitivity, so you need to know that. How are we going to work these patients up when it comes to lower abdominal pain? Of course, the mainstay of workup is going to be imaging, typically going to be starting with a CT of the abdomen or pelvis. Remember, I said it before, the prevalence of serious intra-abdominal disease in elderly patients presenting with abdominal pain is greater than 50%. It is a coin flip. So if you have one of those older patients that has abdominal pain, really low threshold to do a CT of the abdomen and pelvis. Ultrasound is still absolutely an option here, especially in our younger patients if they're presenting with right lower quadrant abdominal pain. If you have a good ultrasound technician, you can use a right lower quadrant ultrasound to assess for a possible acute appendicitis. If the patient's having GU complaints, testicular pain, ovarian pain, adnexal pain, that kind of thing, doing an ultrasound can be very useful to assess for some of these can't miss diagnoses like testicular torsion, ovarian torsion, ectopic pregnancy. Of course, like I said, a pregnancy test to make sure the patient's not pregnant, we need to rule that out. And of course, a urinalysis to see if there's any signs of infection, any signs of hematuria, which could be indicative of nephrolithiasis. We want to be checking for that as well. It's not listed here, but I'm still getting an EKG and a troponin in these elderly patients. Unfortunately, I have diagnosed STEMIs in older patients that presented with lower abdominal pain before, so it's a really quick screening exam, so better safe than sorry. When it comes to these older patients, I have a low threshold to get an EKG and a troponin because I don't want to miss some type of cardiac issue because of a random anginal equivalent. So some of the pearls when it comes to assessing lower abdominal pain, like I said, reviewing prior notes, reviewing prior imaging can be very helpful to see if the patient has had a history of abdominal surgeries or a history of a AAA, and you can get a measurement by looking at a previous CT scan. Or if a patient has a history of an ovarian cyst, that might kind of make us more concerned for a torsion or a ruptured cyst or something like that. And again, I can't stress it enough, do a GU exam. If you're a medical student on an away rotation and you have a patient that comes in with lower abdominal pain and you come to present to me and you tell me that the patient had lower abdominal pain and you grabbed a chaperone and you did a GU exam and here's what you found, that is awesome. You're going to look like a rock star. That is the proper way to manage a patient. So definitely do that. And of course, you don't want to miss something more serious going on like a Fournier's gangrene. As always, guys, thank you so much for watching. If you got value out of this video, drop me a like, drop me a comment, let me know how I'm doing, and be sure to subscribe to receive all of the videos in this series so that you are prepared for your away rotations. Click here on the left to watch that sub-I series video on upper abdominal pain, and click here on the right for another video that YouTube thinks you'll enjoy. Thanks for watching. I'll catch you in the next one.